تفضلي يا دكتورة. Let's begin with the case report.
Okay, let's continue with this case report. The case with chipped porcelain. This is implant supported FTP. You have two fractures in these two teeth or porcelain chipping. One of them is smooth and the other is a cohesive fracture. But in the middle or in the center of the palatal surface, there is an adhesive failure, so the zirconia core was exposed. So for the tooth, with the minimum chipping, the authors decided to do just simple polishing and leave it as it is. And for the other tooth, where there is exposed zirconia core, the decision was to replace it with a porcelain veneer that would be bonded to the old restoration. So they did a window veneer preparation, and they maintained all the margins, marginal areas. All these areas are within porcelain, so the margins are porcelain all around. Okay, here the fabricated veneers. Here it's checked for the marginal fit and the color matching. And here the surface treatment of the veneer with hydrofluoric acid for 20 seconds. And this is for the veneer, and the surface treatment for the preparation surfaces, they did intraoral hydrofluoric acid for the porcelain and air abrasion with alumina particles for the zirconia. And then they applied the primer, silane coupling agent, and metal and ceramic primer, and then conventional resin cements to bond the new veneer to the old restoration. And here is the final result. Okay. Now for the zirconia-based restorations, for the bilayered zirconia restorations, there is another complication. It's not as common as chipping, but it still occurs sometime, which is the framework fracture. And studies have demonstrated that these fractures have nothing to do with the material itself. It's related to other potential causes, as we will discuss in the upcoming slides. Okay, the one potential factor, and it's actually the most common cause, and the one that plays a major role is the size of the connector, the height and design of the framework connector. So core fractures of all ceramic FTPs are dependent on the connector size. So it's the recommended size of the connector is 9 square millimeter, which is the bare minimum. It's strongly recommended for 3 units FDP made of zirconia, bilayered zirconia. And even monolithic zirconia are still associated with such fracture if the connector is small. Okay. The other reason is not following the manufacturer's handling in dimensions. It has been reported that this one is responsible for more than half of the framework fractures when the technician or the clinician are not or do not stick to the instructions of the manufacturer regarding thickness in the handling of the material. Okay. Other potential cause is the exposure of the zirconia framework resulting from occlusal adjustments in the clinic. This can induce or contribute to the onset of fracture. Okay. Also, the presence of ceramic restoration as an antagonist also associated with or can be considered a risk factor for framework fracture because natural teeth have low modulus of elasticity, so the opposing zirconia restorations are subjected to less load than when the opposing is ceramic restoration. Chewing stresses also applied during mastication can also produce surface damage to the restoration, leading to the fatigue failure, aging of the restoration. Okay, now we are done with the fixed over natural teeth. Now we will talk about complications of implant restorations. This is a systematic review for the clinical performance of all ceramic implant-supported single crowns. The peak of the systematic review was as follows. The population were partially idiotious patients. The intervention was prosthetic rehabilitation with all ceramic implant-supported single crowns. They included all ceramic studies on all ceramic materials, zirconia-based, alumina-based, and we will see in the next slide, lithium disilicate and hybrid ceramics. The comparison was not performed because they only evaluated the survival rates, and the outcomes were the survival and technical complication rates on implant and crown level. The estimate survival values for implant-supported single crowns were 93% after 5 years and 94% after 10 years. The technical complication rates after 5 and 10 years were as the following. Chipping was the most commonly reported complication. It was 9% after 5 years and 2.7% after 10 years, and then followed by screw loosening, 3.6% after 5 years and 5% after 10 years, and then framework fracture, almost 2% after 5 years and 1% after 10 years, and debonding or decimentation, 1% after 5 years, and there were not available data to estimate the percentage after 10 years for the debonding or decimentation. Okay. They did comparison for subgroups comparisons for the effect of the material on the survival rates. And they have found that for all ceramic materials, there was no significant difference except for the hybrid ceramics. As we can see here, all the ceramics were ranging, the survival rates of all ceramics were ranging from 91% to 96% for alumina, oxide, deuterium stabilized zirconia-based, alumina zirconia, lithium disilicate. And here we have for the hybrid ceramics or resin network ceramics, it's 67% the survival of the restoration. So it's significantly lower than the other ceramic restorations. Okay, now we'll talk about each complication and how to manage. First is screw loosening. It's the most common was chipping, but we already talked about it. It's basically the same for the fixed restorations. For screw loosening, the incidence of screw loosening varies from 2 to 45% of implant restorations, and the single crowns are more at risk for screw loosening than multi-unit bridges. The posterior teeth are at higher risk than anterior implants, because they are subjected to more occlusal loads, and this supports the claim that eliminating the unnecessary occlusal of access loads can reduce the risk of screw loosening. Okay, now we will talk about preventive measures to prevent or avoid the incidence of screw loosening of implant restorations. First, the implant screw should be retightened 10 minutes after the initial torque application, and then we should do mechanical with we should do the torque with mechanical torque gauges, not with hand torquing, not with only hand. So to make sure that the screw is tightened to the recommended torque values. So hand torquing is not enough. Okay, we should also ensure that the implants are placed perpendicular to the occlusal plane. As we can see here in the figure, placing the restoration of axis, the implant position can cause lateral forces which can concentrate at the implant abutment connection and cause screw loosening. We should also minimize the cantilever for the implant supported restorations. Also, we should use components with low tolerance level of misfit for the FTPs or multi-unit bridges. Like we can see here, we should use non-engaging because it can passively fit much easier than the engaging components. The misfit is one of the factors for screw loosening. On the opposite, for the single restorations, we should use components with anti-rotational features, like we see here, engaging. We should use engaging abutments, like we can see here in the figure on the left, because it's more stable. Okay, this is a review. It's a recent one. I think it's 2023 or 2024. The author proposed a classification for the abutment screw fracture, and they classify them as class 1, class 2, class 3, based on the design of the abutment screw. So we can see here the design of the abutment, the abutment screw. We have the screw head, screw shank, and the screw threads. Okay. So fracture class 1, when the stripping of the abutment occurs at the screw head, when we have stripped head of the abutment screw. This is class 1. And this can result from applying excessive forces to the screw head or improper engagement of the driver. And it's mainly occurs when we use substitute driver to that of the original company. So it's mainly at the head of the screw. Class 1, when fractures occur in the screw shank, which the screw shank extends from just below the head of the screw and to the first or just above the first screw of the abutment screw thread. Sorry, the first thread of the abutment screw. So when the fracture occur in the shank area, it's considered class 2. And this one is not common because this area is not an area of stress concentration. So it's mainly when it happens, it's mainly due to masticatory load in the posterior region of the arch. Okay, so class 3, when the fractures occur in the screw thread, اللي هي apical port, most apical port of the screw. And this is the most common one and the most difficult to retrieve. These fractures occur mainly due to the high occlusal loads in the posterior region. And this area, the studies have shown that this area, the beginning of the threads of the screw, is the area of the maximum bending stresses. Okay. Now there are plenty of techniques to retrieve or to remove the screw according to the position of the screw. But I only have one here for the class 2. You can see here in the X-ray, it's class 2, and almost at the shank level. So here is the X-ray of the fractured screw after crown removal. Sorry, I forgot to add here after crown removal. Okay, and here the authors used tapered pair to prepare a notch at the occlusal surface of the screw. So they placed the notch at the occlusal surface or the screw just between the center and the periphery, so they don't scratch the internal surface of the implant. We can see here in the figures the exact position of the notch Here the N is the prepared notch, and you can see how far it is from the center and how far it is from the peripheries of the screw in order to protect the internal surface of the implant. Okay, so after they place the notch, they use ultrasonic scaler with very low speed, and they mechanically tap the scaler and start to move it counterclockwise until the screw was removed. And here is the X-ray after the screw removal. Okay. Now we'll talk about the implant maintenance protocol. As we know, the key to successful implant therapy is strict maintenance protocol and patients' compliance to oral hygiene instructions. Because despite the long-term predictability of implants, complication can still happen. And in order to prevent these complications, we have to make a strict maintenance program for the patients and regular professional hygiene care. And the patients with active disease like periodontitis must be treated properly in order to prevent the progression of the disease and eventually the loss of the implant. Okay, so for the implant maintenance protocol, we have two protocols, the professional hygiene care at clinic and the at-home implant care. The at-home implant care includes brushing, using soft brushes, or for the patients who are medically compromised or struggling with the conventional approach, they can use electric toothbrushes to clean the surfaces of the teeth and implants. And they can also use interproximal cleaning. We see here the purple one is approach specified for implant restorations, or specifically made for implant restorations, especially when there is wide interdental spaces between the implants. Okay, well, water irrigation is useful for patients who also have problems with using interdental brushes and floss. Okay, for the professional hygiene care, these sessions must be scheduled every 3 to 6 months, and it depends on each case and how this case how much this case is at risk for developing periodontal disease, for example. Okay, so we do scaling and polishing. The scaling, as we know, must be done with plastic instruments in order to prevent scratches of the implant body and the abutment. And the polishing, the implant surface, the abutment surface are already smooth enough. So we only do the polishing to remove the plaque. So we can do polishing with rubber cups with non-abrasive polishing pastes, such as aluminum oxide, tin oxide. Okay, now for the recall visits, we should do periodic examination. What should we do with this examination? We do probing. The probing is to detect any active disease. So we look for signs of pre-implantitis, for active bleeding. And when we do probing, we should avoid, if we have teeth with periodontitis, we shouldn't do probing for these teeth and then go on to do probing on the implants, because we take we move the loads of the bacteria from the tooth to the implant. We can also use, or we should also do radiographs to check for bone loss, and this can be done in each year, for example, to check for the bone level around implants. And finally, we should do occlusal analysis, because as you know, the implant should have the light contact at maximum intercuspation, and the occlusion must be checked regularly because it's changing. Teeth can over erupt, and the occlusion may be established over the implant, like it is over the adjacent teeth, and we must check them regularly to do occlusal adjustments. Okay. And finally, thank you.
Thank you very much, Dr. Rafaf, and we'll continue, inshallah, after the break with our comments, inshallah.
Yes.
Thank you very much.